This is the podcast of the American Journal of Psychiatry Residence Journal. I'm culture editor Erik Bayona, and I'm here with Dr. Sidhu at UNM. Welcome, Dr. Sidhu.
Thank you for having me.
So I'd just like to start off with asking you a little bit about your background. I know you're a child psychiatrist. What kind of other things do you do here at UNM, and overall, what brought you to New Mexico?
Yeah, that's a great question. I grew up in Ohio and I went to medical school in Ohio. And then I went to Chicago to do my residency and then Los Angeles to do my fellowship. So I've sort of made my way around the country, as many of the listeners probably will have. And so what drew me to New Mexico was the opportunity to work with underserved populations, both in terms of the entire state is underserved. So we have about one child psychiatrist for every 8,000 children. And we can estimate that about 1,700 of those children will have a mental health issue. So there's a severe shortage here. Almost the entire state is underserved. There's a considerable amount of children who are in poverty. So child poverty is very high in the state. Unemployment is high, and we struggle with education as well. So I thought it might be an opportunity to help people that really need a lot of help. We also have unique populations in this state. So we're fortunate to be home to a number of Native American tribes. Most tribes are Pueblo, some Navajo, some Apache, and then some other tribes as well. And we also, because we're, by virtue of being a border state, we do have a considerable number of people who have been detained, who are seeking asylum, and other folks who have crossed the border for one reason or another. And so within New Mexico, although the entire state is underserved, we have a number of special populations as well. The great thing about working at the University of New Mexico is that we have a very developed health sciences research center. And the entire goal of the research center is to address questions about access to care. So through our research center, we have innovative programs such as telepsychiatry, home visiting programs, juvenile justice programs, school outreach programs. In addition, we've been undertaking efforts to train mid-level providers. So that would be, and actually that's not a politically correct term anymore, I would say, we've been undertaking efforts to train advanced practitioners, which would be nurse practitioners and physician assistants and school nurses. So there's all kinds of innovative things that are going on here to try to address this issue of decreased access to care. And that's primarily what made me excited about coming out here.
Great. Yeah, there's definitely a drastic need. I wanted to ask you about your involvement with Indian Health Service, otherwise known as IHS. What's your work with IHS entailed, and what kind of experiences have you had there?
Yeah, so Albuquerque is home to the National Telebehavioral Health Center of Excellence. So the acronym is TBHCE. But that means that the Indian Health Services hub in Albuquerque is in charge of providing telehealth to the entire nation. So not only do we serve tribes in New Mexico, but we also serve tribes in Arizona, Nevada, Montana, Wisconsin, North and South Dakota, Massachusetts, New York. It's pretty much all over. So it's been amazing to see how we can use technology to kind of drop into a clinic where the nearest city might be 3 hours, 5 hours. And it's a great feeling to get knowing that you're providing this service for them and that if you weren't there, there would be nobody. And the patients are such a pleasure to work with. They are very strong, resilient. I love learning about their culture. They've shared a lot of their lives with me. So I've been absolutely thrilled with this opportunity. We also use the same telehealth technology that we have to do trainings. You know, for example, in the morning, I might be doing the clinic and using our telehealth equipment to see patients. But that afternoon, I might be doing a training on, let's say, dialectical behavior therapy for adolescents. And the same sites that get the care, they get these webinars broadcast out to them. So we can simultaneously train people in rural areas in important topics in child psychiatry. So the other thing you can do with Indian Health Services, which is a federal, I think some people don't know it's a federal organization, much like the VA is. So it's federally funded. It's a national organization. For some people, it might be interesting to know that because it's federal, you don't need a state license in the state where you practice if you're working for Indian Health Services. So
interesting.
because I work for IHS, I can do telehealth in 5 states, but I only have a New Mexico state license.
I see. Yeah.
So sometimes if somebody really wants to live in, let's say, California and Texas are notorious for having difficult medical boards, you could live there, but use another state's license to practice telehealth or something like that.
Yeah.
So you can also do on-site service, which I've really enjoyed. I was at one of the pueblos, and I got to help create a school-based health sort of service line for child psychiatry. So that involved doing home visits, getting to know people in the community, going for feast days, participating in their cultural activities. And I really, really enjoyed that as well. If you're interested in doing schools work, you get to walk around the school, talk to teachers, refer kids for special education, observe them in the classroom. It's a really nice way of getting out there. And then you can educate the families and the teachers on important topics as well. So there's a lot you can do through Indian Health Services. I'm sure I'm even missing some of the elements.
It's a pretty wide range of things you can be involved in.
Absolutely. It's also worth mentioning that some tribes decide not to use Indian Health Services, and they can contract with the federal government to receive that money and independently contract on their own. So, for example, a tribe may say, we don't want Indian Health Services. We're going to hire our own primary care doctor, our own psychiatrist, our own child psychiatrist. And so it's possible to work with Native Americans even if you're not working through Indian Health Services, because you could work directly with the tribe. So there are a lot of different options for Native health, but it's definitely a need out there. So we want folks to hopefully practice in Native areas or do telehealth with Native patients.
Yeah, definitely. From your work, what are some of the important mental health concerns that you've seen in the Native American community?
Yeah, and I think the way that I like to talk about it is really talking about this concept of historical trauma. The idea is when you have trauma happen to a single individual one time, then you could do something like TFCBT, right? A narrative trauma-focused approach where somebody tells their story and eventually they see it as post-traumatic growth and resiliency rather than post-traumatic trauma or stress. But when you have historical trauma, you get generation after generation after generation after generation. And that has a profound cost to the entire community. It's not just one individual anymore. It's nearly everybody in the community has been traumatized, and that has a devastating impact. Then when you put on top of that the impact of most of these reservations, if you drive out to them, there's nowhere to work. There may be one casino or one gas station. And here in New Mexico, there aren't really even animals that you can hunt. It's a desert, right?
Right, yeah.
So employment is very hard to come by on a reservation. If you don't work for the tribe or the gas station, then you're out of luck. So there's poverty. There is a lack of services, both medical and mental health. And so, unfortunately, you do see higher rates of suicide in Native Americans, and especially adolescents are 2 times as likely to experience death by suicide, and then transitional age, which is defined epidemiologically more as like sort of 25 to 40, so sort of middle age, is 7 times higher in Native Americans than the national population. But interestingly enough, it's the exact opposite of the nation in the sense that once people get to about 50 or so, in Native Americans, their suicide rates drop. So we tend to think of like older white male, right, as being the highest risk for completed suicide. But in Natives, it's almost the exact opposite profile, that you're at risk in your youth and you're at risk in your early middle age. And then if you make it that far, your risk of suicide is very low. So that tells me something about, number one, how difficult it can be in general when you're trying to find intimacy, and all the sorts of suicides that I've seen have been in the context of relationships and things of that nature. But that there's a lot in the culture that once someone has a sense of who they are and how they define their life, they get to that middle age range. It actually is a huge protective factor. And so, although there is poverty, although there are significant mental health issues. I've also found Native American communities to be some of the richest in the culture, tradition, spirituality, values. So I get a little bit uneasy when I hear people talking about working with Native tribes as those poor people or those, there was this TED Talk that I was watching the other day that was actually on refugees that was talking about don't feel sorry for them, but rather believe in them.
Mm-hmm.
If you feel sorry for someone, you sort of unintentionally disempower them. But if you believe in someone, you feel like this person can succeed despite the challenges that they're going through. So to me, there are vast riches in culture and spirituality and resilience and extended family. Another thing that's interesting about working with Native communities is coming from Chicago and LA.
Mm-hmm.
A lot of times if the kids' parents were unable to take care of them, the youth would go to foster care. In Native communities, the extended family is so strong that even if mom and dad, or let's say one is incarcerated, one may have a substance abuse disorder, somebody in the family is going to take care of the kid. It may be grandma, grandpa, it may be aunt or uncle, it may be a cousin or a brother. So the strength of the extended family is impressive as well. So I've found the communities to have a lot of strengths, but unfortunately as a result of historical trauma, there are some challenges as well.
Wow, yeah, that's definitely very significant. One of the other things that you mentioned just now, another population that's also in high need is the refugee population, which I know that you've also had some experience working with. Can you tell us a little bit about how you came to work with refugee populations and then even start doing asylum evaluations? How did that happen?
Right, and maybe the first step is sort of understanding the difference between these terms because they get confusing.
Mm-hmm.
So immigrant is somebody who's from another country, right? Mm-hmm. So that's the kind of broad umbrella term. Mm-hmm. Then we get into a lot of different legal terms. So somebody who presents to the border and asks for asylum is an asylum-seeking immigrant.
Okay.
They're actually termed by the government as an alien.
Okay.
They're all given what you call an A number, which is an alien number. For obvious reasons, mental health professionals don't use the language of alien.
Right.
Because it sounds, it's not an endearing term. It's not even necessarily a humane term. So I prefer asylum-seeking immigrant. And then if that person goes on to get asylum legally, they present their case to a judge, and the judge says, I think you meet criteria, then they're called an asylee. A refugee is slightly different. So a refugee leaves a country where they are facing persecution or being threatened or tortured, and they go to another country. And from that country, they can seek asylum or they can seek refugee status in that country or another country. So typically when people are refugees, some of them have been pre-screened before even getting to the United States and been given refugee status. It's a little bit confusing.
Yeah,
it sort of depends on whether you presented to the border or whether you were sort of accepted from overseas. Maybe the easier way to distinguish it. So I think one thing that's important to go over is what are the criteria for seeking asylum. Mm-hmm. You have to be able to make the case that you've been threatened, tortured, persecuted on the basis of something about you that's definable. So it could be gender, it could be race, ethnicity, religion, it could be LGBT designation, and depending on where you are, it could be a kind of like a gang, non-gang, whether you're part of that social group. But that varies drastically based on who the judge is. And, for example, Canada is more likely to grant people asylum for gang-related violence than the United States is.
I see.
And Colorado and San Francisco are more likely to grant it than El Paso. So each jurisdiction kind of has its own way of interpreting the law, even though the law is the same. But that's the basic understanding of what the criteria are.
I see.
So when I'm doing an evaluation, a forensic evaluation, I need to find out not only if they have any mental health conditions like PTSD and things like that, and explain to the judge and the attorney why their clinical presentation is consistent with someone who's been traumatized, but I also need to make some sort of a tie into why the trauma was secondary to one of these criteria. So this person was trauma. I work with a lot of transgender people, and so transgender women. So they oftentimes are making the claim that being transgender is illegal in their home country, or it's not illegal, but they have basically no legal rights, or there's exploitation. They make some sort of a claim that because of this, then they've had the trauma. But the important thing to note is that you can't treat someone when you're doing a forensic asylum evaluation. It's a purely legal assessment. And then it's a strange feeling because you meet this person, they tell you all these, really intimate details about their life, and then you just walk away. You write your report, you give it to the attorney, you wait kind of tensely for a few weeks, then you get a call. Most of the time, almost all the time, the call has been favorable where they say this person got, won their freedom, which is great to hear. And then they go on to being resettled and can seek treatment.
So then what do you do in that case when you go in as a doctor and you're evaluating a person, and you're, as a psychiatrist, and you know that they do need treatment? What do you do in that case?
Typically, as a forensic interviewer, you can make recommendations to the attorneys and the judge. So you can say, I talked to this person today and they're telling me they're actively suicidal. If this person was seen anywhere but this ICE detention facility, I would be sending them to an acute hospital. So you can make recommendations in the acute sense that this person is psychotic or they're suicidal. Then at that point, the prison may or may not decide to follow your recommendations because technically these individuals are not citizens. So then the other thing that you can do is you can make the case about, okay, I do think this person has PTSD based on all these criteria. And I know that we have effective evidence-based treatments in the United States that they may not have access to elsewhere. And so not only did this person say to me that if I go home, I fear to my life for X, Y, and Z reasons, they also wouldn't be able to get the treatment that they need. So that's something that we usually put into the recommendations for the judge and for the attorneys.
Are there any patients or any people that you've met seeking asylum that their cases stand out in your mind as to something that you would feel comfortable sharing for the listeners here, of something that was just so intense, or their story was just so dramatic that you almost were taken aback by it?
Honestly, the stories are so graphic. I almost hesitate in talking about them in a lot of detail. What I would say is that people have gone through unbelievable amounts of trauma and torture, unlike anything I saw even working in Chicago, where I had a couple patients from South Chicago that's notorious for a high murder rate, and even in working in Compton when I was in LA. This is just something else. It's a totally different world. It makes you feel thankful to be in this country, even though we have clearly a bunch of problems. So the murder rate is very high in Central America right now, as people probably know that the highest murder rates are in the Northern Triangle, which would be El Salvador, Guatemala, and Honduras. And a lot of these unaccompanied minors are coming from, though people have been hearing about unaccompanied minors crossing the border without parents.
Right.
A lot of these unaccompanied minors or the family units are coming from Central America, and they're fleeing gang violence. So how bad is the gang violence if we were to quantify it? There's one study from 2014. The author is Restrepo, Restrepo. And in that study, they make the argument that there are actually more gang members in these 3 Central American countries than there are police and military personnel. So that's how large the issue is. If you were to compare the level of violence or the murder rate, not only is Central America much more dangerous than New Orleans, Flint, Michigan, Chicago, our most dangerous cities, it's actually more dangerous than Iraq was at the height of the insurgency. So it's basically a state of war. It looks different because it's gangs and not tanks and things, but it's a pretty tough situation. Then I've had a number of other cases from Africa where a lot of places in the world it's still illegal to be LGBT. In some places in the world, you can be killed for being LGBT.
Can be killed?
Yes, this capital punishment is the sentence for being an LGBT person.
Gosh.
So we think like, oh, the Supreme Court passed gay marriage a few years ago, and so the rest of the world, no, not at all. It ranges from LGBT status is punishable by death to we're just not going to protect you. Basically, that's the range of it. So a lot of folks are experiencing that type of thing. And then, of course, there's the Middle East and Syria, and overall 65 million, 67 million people displaced at this point, which far surpasses World War II, which is about 40, 50 million. So this is a global issue right now. The nice thing about doing asylum work is you feel like you actually get to do something about it.
Right.
Even if it's one drop in the bucket, sorry. You get enough drops in there and eventually it does something.
It does make a difference.
I think so.
Yeah.
I think so. For that one person, it could mean the difference between life and death.
Yeah. Definitely.
And how can we say one life isn't valuable?
You mentioned a little bit, and it's been in the news recently too, about unaccompanied minors. Why do you think there are so many unaccompanied minors coming to the U.S.? I know you mentioned a little bit about the violence, but would there be other reasons as well?
Yeah, absolutely. So the violence, you can sort of break that down into several of the young men. These are more like adolescents or transitional age folks that I've interviewed have said that essentially the gangs have given them ultimatums that you join us or else. And they didn't want to join the gangs. So they felt like they had really no alternative but to leave. And so I think in some cases parents are fearful of the fact that their child will either be recruited into a gang or they'll be preyed upon. And they feel like, can you imagine, a lot of us are parents, how insecure you'd have to feel to send your child hundreds of miles away from you with a complete stranger or set of strangers, knowing very well that they might actually get traumatized on the journey to the United States. It'd have to be pretty bad, right?
How bad would things have to get for it to get to that point?
Exactly. I'm a parent. I could never imagine. I mean, I can't even leave my kid out of sight for 5 minutes at a playground, right? I could never imagine sending my kid hundreds of miles with a stranger, knowing that on the way that they oftentimes get traumatized. But if it was bad enough, you would do it.
Yeah.
So I think it just speaks to how difficult things are.
And that's some people's reality that they have to do that.
Right.
With all this, with knowing that and knowing the trauma that we'll go through and the violence that they face, what type of emotional impact has that had for you doing this work? And how has that changed your practice and your approach to medicine?
Yeah, absolutely. It's a good question. And I think this applies more broadly to anybody who's interested in psychiatry or child psychiatry is going to have to confront the same thing, which is that you hear a lot of traumatic stories. And it can be difficult. I think you have to have ways of handling that. Otherwise, it can probably lead to things like burnout and probably affect your home relationships, the quality of your life. So the first few times I did asylum evaluations, I was very impacted by it. I remember driving home and just sort of staring blankly. It's an hour and a half drive, so I had a lot of time to stare blankly. Over time, I think it's gotten a little bit easier to try to compartmentalize it, but it definitely helps if you have something that is a release for you, whether it's exercise or creativity or a way for you to get it out. And then when you get the call, I think that's the thing, is when you get the call, it's such the opposite emotion of bliss and joy and just, feeling so happy. It's so meaningful. It's so rewarding. Then I think that the next time you go and you do the evaluation, you feel like there's some end result to this. It's not just hearing about trauma and having someone tell about trauma for the sake of trauma. The second point I'd make is that more than one of these clients have told me afterwards, even though it was hard to talk about that, I think it actually helped to talk about it. And that would go in line with what we know about trauma-focused CBT. So we might feel like, oh man, we're hurting this patient by asking tough questions.
Yeah.
And for some people, it may be re-traumatizing. For some people, it may help them to have control over their narrative and to take control over it.
So we've talked about several issues here and kind of kind of in the context of this modern world that we face, where there are several kind of social problems and we're one part of it. It's easy to feel like disempowered, like there's so much and, I'm just one doctor, I'm just one psychiatrist, I'm one, maybe a medical student or a resident, and what can I do, And what would you say for someone like that or even someone who's an attending that, is busy and yet is paying attention to all these things going on in the world? What can we do?
In general, if you live in a bigger city, there's probably a refugee treatment center or a torture survivor treatment center that you could just plug into, which would be easy in a sense. I think our story here in New Mexico might be worth sharing because the lesson I take away from that is that persistence is the key, and that if you persist, you can accomplish just about anything within reason. So it was pretty remarkable. I started hearing a few years ago about unaccompanied minors and all the violence in Central America, and I wanted to help.
Right.
And so I started talking to Physicians for Human Rights, which is one of the largest organizations that helps physicians get trained in how to do asylum evaluations, and then will actually refer cases to them.
Okay.
And they were very nice. We talked for about a year, and I was thinking, man, it would be great. I really want to do this work. Maybe I could write a grant, and Physicians for Human Rights could come out and train us. And so I got ready to write the grant, and as soon as I was about to write the grant, I got an email from Physicians for Human Rights saying we don't have the resources to support New Mexico right now, which was pretty devastating. I had all my hopes in this one, I'm going to get the money. It's a little bit of money. It's an ACAP grant. Right. It's called an Advocacy and Collaboration Grant, and that'll cover the charge, and then I'll learn it, and other people will learn it. Mm. So then I was like devastated, and I just I wasn't sure what to do. I started asking around. It turned out there was one faculty member who had done this kind of work in the past. So I met up with him. He sat with me for a couple hours and showed me how to do an evaluation, but there were no lawyers. Mm. So you need lawyers.
Yeah.
So I started asking around if people knew lawyers. I said, well, there's this one law firm. I went to talk to that one law firm. They said, we're no longer doing asylum cases because we never win them. So now I'm stuck again. I got a little bit of training, but I don't have a lawyer. So I'm asking. Finally, someone tells me about this new group of attorneys from Santa Fe called the Santa Fe Dreamers Project, who are taking these. And I wouldn't have known if it wasn't just a friend who told me about it.
Yeah, word of mouth.
Yeah, so they started taking these asylum cases for people who are in this big detention facility. It's basically a prison, about an hour and a half west of Albuquerque.
Okay.
So I got in touch with their attorney. There was one attorney there. And she said, I've got this case. Can you do it? And I'm thinking, the whole imposter syndrome thing. I've never done this. I'm probably going to screw it up. But she said, you're all we got. And this person, I've got a deadline of a week and a half. And he's going to get deported. And I have reason to believe that if he goes home, his life will be in danger. So I went and I did the evaluation. I did feel like kind of inconsistent about it. Like I wasn't sure if I was doing the right job and doing the best I could. I did it. I sent it to that faculty member to proofread it, turned it in, and he ended up getting asylum. It was a great feeling. So I started doing more of these cases. Then they started getting more attorneys at this nonprofit. And then we started doing about 1 or 2 a month regularly. Mm-hmm. But then they started asking me, can you do more? Can you do more? Can you do more? And each one of these is about an 8-hour investment. So you can only do so many of these in a month without working basically a second job. So then we started thinking, how can we train people in New Mexico? Even though I've never thought of myself as a trainer, I wouldn't consider myself to be an expert, but I've seen one and I've done one. Can I teach one? Mm-hmm. So we wrote the same grant application that we were going to write for Physicians for Human Rights, but we wrote it with ourselves as the trainers. And it was incredible to see the response. I thought, man, if we could get 15 people to this training, maybe we could get 1 or 2 more volunteers out at this detention center. And that would be great, because now we'd have 3. And from 1, that's a big improvement, right? Mm-hmm. So, but it ended up happening that people were way more interested in this than I had anticipated. So 100 people registered for this training. and 70 people attended. 15 people attended via Zoom, and people attended from Texas, even as far south as El Paso, as far north as Taos, New Mexico. And now the attorneys are telling me we've quadrupled our volunteers who are doing mental health evaluations at the detention center. So I think what I've learned from this is really it's just about persistence.
Yeah.
If I would have given up that when Physicians for Human Rights said we're not going to invest in New Mexico, nothing would have happened. But one thing kind of led to another and another. And if I have any advice to the medical students and residents and fellows, or even early career psychiatrists, it would be, if you hit a dead end, just keep pushing and keep exploring. You'll probably find some way to get past it. But if you give up in the beginning, you might not be able to achieve your full potential. Mm-hmm. And now it's like, it feels incredible that we've been able to do it. But back then, a year and a half ago, there's no way I would ever have imagined that we would be doing the training, having never even gone to a training myself. So it's been great. Now we're trying to create a whole Southwestern network. Next, we're going to go to El Paso, do a grand round, do a training down there. So we're trying to kind of develop a regional network of people who do this work. So let's see. We'll see where it goes. But it's definitely been an eye-opening experience.
That's great. Yeah, thank you so much for sharing your experience. And thank you for joining us today.
Sure. Thank you for having me.
Really appreciate it.
Take care.